Welcome to this explainer. If you've ever felt completely overwhelmed by the sheer number of possible causes for swollen legs, you are in exactly the right place. Today, we're diving into a really brilliant, structured framework for diagnosing lower limb edema. We're going to master this clinical challenge using an absolutely unforgettable set of mnemonics. Seriously, by the end of our time together, you'll have a complete mental map that will let you diagnose leg swelling quickly, accurately, and above all, safely. So let's jump right in.
Here's our roadmap. First up, the golden rule of edema. Second, we'll look at local causes for when one leg is swollen. Third, systemic causes for two legs. Fourth, our look, feel, ask, test clinical approach. And finally, a quick 1-minute memory recap.
All right, starting off with Section 1, the golden rule of edema. This comparison right here, this is the master rule you have got to anchor in your mind. Say it with me. 1 equals local. 2 equals systemic. It really is that simple. If a patient presents with just one swollen leg, your brain should immediately jump to a localized issue in that specific limb. On the flip side, bilateral swelling, that screams of a systemic failure or maybe a broader venous issue. Now, sure, there's a tiny caveat that bilateral DVT is technically possible, but it is highly uncommon. So trust the rule. 1 is local, 2 is systemic.
Moving on to Section 2, one leg, local causes.
Okay, so when you see just one swollen leg, I want you to immediately think of 4 letters, DCLI. This simple little acronym is going to save you so much time. It perfectly categorizes the entire differential diagnosis for a unilateral swollen limb.
Let's break those down, shall we? DCLI stands for deep vein thrombosis, cellulitis, lymphatic obstruction, and injury. These are your prime suspects. Whenever one leg is noticeably bigger than the other, the culprit is almost always hiding behind one of these 4 doors. Let's walk through each one so you know exactly what clues to hunt for.
We absolutely have to start with the D, DVT. One leg plus swelling plus pain or warmth equals DVT until considered otherwise. This is your primary do not miss diagnosis. You're looking for typical triggers, a history of recent surgery, immobility, cancer, long travel, or maybe pregnancy. But here is the critical point. Clinical examination alone cannot reliably exclude a DVT. No way. You've got to use a proper diagnostic pathway like a Wells risk score, followed up by a D-dimer blood test or a venous ultrasound.
Rounding out the local causes, we've got C, L, and I. Cellulitis is very visual and tactile. You're looking for skin that's red, hot, and painful. It's usually unilateral, super tender, and the patient might even be running a fever. For lymphatic obstruction, think large, chronic, firm. This could stem from malignancy or a previous lymph node surgery, and over time, that fluid buildup gets really hard. And finally, I for injury. Pretty straightforward, right? Just a history of trauma leading to the swelling, like a fracture or a bad sprain.
All right, let's flip to the other side of the tree, Section 3. 2 legs, systemic causes.
When both legs are swollen, we need to shift our thinking away from localized issues and start thinking about systems failing. The 5-letter mnemonic to instantly recall the major culprits here is H, K, L, V, M.
Let's break this one down. We're looking at 3 major organ failures and 2 other extremely common causes. H is for heart failure, K is for kidney failure, and L is for liver failure. These first 3 represent your major systemic organs basically failing to handle fluid volume or maintain protein balances. Then we've got V for venous insufficiency, which is incredibly common, and M for medications. Medications are an often overlooked but highly frequent cause of bilateral swelling, so definitely keep that in mind. So how do we tell those 3 organ failures apart in the clinic? For the heart, just remember feet plus air. The feet swell and catching their breath becomes difficult. You're looking for breathlessness and a raised JVP, meaning a bulging neck vein. For the kidneys, think protein plus water. Kidney disease often presents with protein in the urine and generalized edema. Finally, liver equals low albumin. Because the liver isn't making enough albumin protein, fluid just leaks right into the tissues. Look for jaundice or ascites, which is fluid pooling in the belly.
Now for the V and M of our HKLVM mnemonic. Let's compare venous and medications. For venous insufficiency, remember the golden phrase, up gets better. Since the issue is blood pooling when they stand, the swelling gets much worse on their feet, but improves a ton when they elevate their legs. You might also spot varicose veins or some darker skin pigmentation. For medications, rely on the acronym ANS. Amlodipine and other calcium channel blockers are classic culprits here. Actually, a patient starting amlodipine and then developing ankle edema is a classic textbook clue. The N is for NSAIDs and the S is for steroids.
Moving on to Section 4, look, feel, ask,
Test.
Okay, please, whatever you do, don't just immediately order every test under the sun when a patient comes in with swollen legs. Instead, I want you to methodically step through this actionable pathway. First, look, is it one leg or both? Are there skin changes, redness, or ulcers? Next, feel. What's the actual texture of the swelling? Third, ask. Take a highly targeted history to find triggers. And finally, test. Only order labs or imaging based on your specific suspicions. Let's actually zoom in on the feel and ask steps for a second.
A really crucial part of the feel step is identifying pitting edema. This is when you press into the skin and the indentation just stays there temporarily. Finding this points you directly toward fluid accumulation. If it's bilateral and pitting, boom, you should instantly be thinking about our mnemonic: heart, kidney, liver, venous, or medication causes.
Contrasting these two physical findings makes your diagnosis so much easier. While pitting edema points to systemic, venous, or medication issues, non-pitting edema points elsewhere entirely. If you press the skin and it springs right back, meaning it doesn't leave a dent at all, you need to immediately suspect lymphatic obstruction or myxedema, which is a severe thyroid condition. That simple tactile feedback literally splits your differential diagnosis right down the middle.
When you're executing the ask step, use the super efficient time trigger system framework to quickly narrow down the suspects from your mnemonics. First, figure out the time. Is this acute, happening over a few days, or chronic, over months? Second, hunt for a trigger. Was there a recent surgery, a long flight, physical trauma, or maybe they just started a new med like amlodipine? Finally, ask about the system to check for those organ failures. Are they breathless? Is their urine frothy, indicating protein loss? Do they have any jaundice?
And finally, the test step. As we mentioned, you should really only order tests that target this specific suspicion you've developed from your history and physical exam. If you suspect DVT, follow the pathway Wells score, D-dimer, or venous ultrasound. Suspecting heart failure, go for an ECG, a chest X-ray, and a BMP, which is a hormone indicating heart stress. If it looks like renal disease, you'll need a urinalysis and electrolytes. And for the liver, target those liver function tests and albumin. The key takeaway, let your clinical findings dictate your tests, never the other way around.
Which brings us to Section 5, our 1-minute memory recap.
All right, let's burn these mental models into your long-term memory right now. This is the entire explainer condensed. The master rule: one leg points to a local problem, two legs point to a systemic or common venous problem. For one leg, your mnemonic is DCLI, DVT, cellulitis, lymph, injury. For two legs, it's HKLVM, heart, kidney, liver, venous, medications. Seriously, if you can just recall these two acronyms, you will never be lost evaluating lower limb edema again.
Before we wrap up, I need you to never ever forget this ultimate safety mandate. Sudden unilateral swelling, especially when it's accompanied by pain or warmth, requires a prompt and thorough assessment for deep vein thrombosis. You simply cannot rely on your clinical exam alone to rule it out. Always use your diagnostic pathways to ensure patient safety.
Armed with these mnemonics, you are officially ready to tackle leg edema systematically and confidently. So I'll leave you with this thought. The next time a patient walks in with a swollen leg, which branch of your new mental decision tree are you going to explore first, DCLI or HKLVM? Thank you so much for joining me for this explainer, and keep exploring these fascinating clinical pathways.